at Penn has been a huge foundation in my career in bioethics, both during my PhD and now as I'm transitioning into my postdoc program. So the presentation that I hope to share with you today is my own personal reflections in terms of the current progress in both cell and gene therapy globally, but also the work that we are currently doing in Tanzania. And I'm a non-clinical person, so I'm approaching this talk in a bioethics way, but also I'm including some of the work that we have been doing just to strengthen some of my arguments that I want to make at the end. And the questions that I'm asking myself as I'm doing this personal reflection today here with you as my audience is, are we raising our hopes too high in terms of dreaming to have gene therapy programs for sickle cell disease in Africa? And specifically, I will share experiences in Tanzania. And as I reflect this question, I hope you guys will also be doing the same throughout the presentation. Mind if I turn the camera on? So I also wanted to make one point. I've chosen a very strategic audience to share this presentation today because of the work that Penn has been doing in gene therapy programs. You guys are leading in these spaces, especially from bench to bedside. So a lot of what I'm also sharing, I hope you guys will also be able to reflect with some of the programs that you guys already have here. I attended the SGCT meeting, and I was fortunate to also attend some of the sessions that were led by people from here. And one of the things that I was extremely excited of was the CHOP program, the Cured program, which is extremely similar to what we are aiming at, but not that high level kind of thing. So it's such an intentional audience to do this reflection, because I know, guys, you are at the right place to do this reflection with us. So the burden of sickle cell disease is high in Africa. So majority of patients with sickle cell disease are in Africa, and it is estimated that 300,000 children are born with sickle cell disease annually. And without intervention, 50 to 90% of these children, depending on where they are born, will die before 5 years of age. But also I've learned that the number of children with sickle cell disease has been increasing at a very high level. For example, the data in 2000 has shown an increase of about almost 40% to the data that we currently have in 2021. So this might not be the most reflective number. As we go along, it seems the burden will continue to be high. And specifically in Tanzania, we are fifth in the world for having the highest annual birth of children with sickle cell disease, and it's much more prevalent in coastal and lake zone regions. And currently, the estimates that we have, it's about 11,000 to 16,000 annual births per year. And sickle cell disease is contributing to at least 6% of the overall under 5 mortality in Tanzania. And I'll talk a little bit of the program that I'm currently based in Tanzania. So it has been established in 2004, and this was through a partnership between Muhimbili University of Health and Allied Sciences, which for a very long time has been the one and only public university offering medical degrees program, and our most tertiary hospital, which is the Muhimbili National Hospital. So this was in 2004. But we have seen considerable progress in terms of the expansion of the program itself. So in 2007, we have been able to be part of what is called Sickle Pan-African Research Consortium. So this is consortium of countries, of 6 countries in Africa, so Tanzania included. And part of what we do in this consortia is to do patient registration. And I think one of the ways that this registry will be important is also to see ways that we can improve care for patients with sickle cell disease in this country. So in Tanzania, for the registry in Tanzania, we currently have an estimate of around 7,000 patients registered with sickle cell disease. Most of these registered patients are children, so about 6,000 of those registered, which is above 80%, are children, and only 1,400 are adults. And these are some of the centers where the SPACO register is happening in Tanzania. Okay, so this is the next slide. So again, there has been a lot of local efforts by our government in Tanzania, in collaboration, of course, with Sickle Cell Program and other partners in terms of strengthening comprehensive care services for sickle cell disease. This include like having proper clinical management guidelines for patients with sickle cell disease, strengthening our blood transfusion program, but also making sure that hydroxyurea is much more affordable and accessible to the majority of patients with sickle cell disease in Tanzania. Our national health insurance funding has been revised for over the years to make it much more accessible and affordable to Tanzanians, and therefore indirectly this has had a huge impact to families that have children with sickle cell disease. And again, in terms of vaccination, the uptake is almost 100%, and this is quite essential for children born with sickle cell disease. And of course, those are some of our guidelines for management of sickle cell disease that have been developed for over the years. Yeah, so in parallel with the efforts that we are currently making in terms of strengthening comprehensive care services, there has also been an interest in looking at curative therapies for sickle cell disease, both bone marrow transplant as well as gene therapy. And our government, this was a newspaper, it's a daily newspaper in Tanzania, and it's called Daily News. So this was published in 2019, and there has been a commitment from our government and the Ministry of Health in terms of supporting curative therapies for sickle cell disease and making it much more accessible to patients with sickle cell disease. And this has been quite a driver of some of the work that we are doing, to know that our government is behind some of the work we are doing. And in addition to that, in 2019, again, National Institute of Health, as well as the Gates Foundation, has committed around $200 million to support HIV and sickle cell disease therapies in Africa. So this has been quite a huge motivator to start building advanced therapy program for sickle cell disease, both in terms of strengthening the basic and clinical science studies, as well as looking at other ways of facilitating access to these therapies, and also participating in gene therapy trials for sickle cell disease. And of course, of more recent progress that we have seen are the recently approved treatment for sickle cell disease, gene therapy-based treatment. I think end of last year. So the first one is the Vertex one, and the Bluebird one. So both of these trials are given to children 12 years of age and older. So I think all of this progress in terms of advancement in science has been driving a lot of enthusiasm in terms of how our patient with sickle cell disease, how places that have the highest burden of sickle cell disease will be able to access high-end therapies and quite costly therapies, such as the recently approved. And of course, from the SGCT meeting that I've attended last week, it seems there are more therapies that will be approved in recent years. So for example, this is a screenshot that I've taken from one of the slides from the meeting. It seems that by 2025, FDA will be approving at least 10 to 20 gene therapy products a year. And this is based on the assessment that they have done. And this was a quote from 2019, perhaps now to be even the number will be higher than 10 to 20. So a lot more gene therapy products will be coming out, and hopefully some of those products will be sickle cell disease based. So yeah, so there is a lot more to come. And I think in July 2023 or August, the Lancet Hematology Commission published an article on trying to provide, I think, a guidance or a direction in terms of where we are globally in terms of sickle cell disease care. And of course, they did highlight that in addition to focusing on strengthening comprehensive care services and making sure disease-modifying drugs such as hydroxyurea are much more accessible and affordable to every patient with sickle cell disease, but there is a need to start looking at curative therapy. So I will quote one of the statements here. The ultimate aim is to provide access to definitive or curative therapies for every patient with sickle cell disease, irrespective of where they live, which is quite key for me. And it seems probable that this will involve some form of gene therapy. And also they went ahead and provide a little bit of direction in terms of how, when do they think these therapies might be accessible to patients in Africa. So not necessarily in Africa, anywhere in the world. So based on the ongoing scientific and infrastructure investment to achieve effective, safe, and accessible cures, yeah, it's at least by 2040 that it seems like, based on this report, that maybe some patients with sickle cell disease might be able to access some of the high-end curative therapies. And I also wanted to take a note of the Science Translation Medicine Review. So there are 2 articles that have been published last week in Science Translation Medicine and Review. So one of it is a much more an advocacy piece, and the other review that I've also participated as one of the co-author in trying to also look at the positioning low and middle income countries in terms of the issues of access, and continuing to advocate for on how best can we facilitate access. So I think all of these references are pushing patients, families, clinicians, researchers, and SCD community globally to think of what are the best strategies for us to make sure that we do facilitate access for curative therapies for sickle cell disease in other countries in LMIC, and how is the road towards that going to look like. So I will specifically position my presentation based on some of the framework that have been highlighted in this paper that was published in the Science Translation Medicine Review. So I think the recommendation at the end of this article is to say that it needs a multidisciplinary approach to be able to facilitate access of gene therapy program for sickle cell disease. So these include defining roles of academic and research institutions. What are the roles of government in this particular program? What are the roles of commercial entities and biomedical companies? But of course, at the center of it is how are we involving the study participants in making all of this program work. So it has tried to define who are the key players and what will be their role in each of the stage in building gene therapy capacity in LMICs. So with that, I will, as I previously said, I will use that framework to try to position some of the work that we have been doing in Tanzania in our center towards that. So in 2021, we established what we call the Sickle Cell Disease Advanced Therapy Program. So the main purpose of this program was to work with researchers, healthcare providers, clinicians, as well as patient advocates to find ways that we can strengthen, build partnership, but also to understand and develop capacity of trying to build gene therapy, advanced therapy intervention for sickle cell disease in the country. So these include exchange transfusion program, bone marrow transplant, as well as gene therapy. And our goal was to use a multidisciplinary approach in which the clinical component is also complemented with advocacy, research, training, as well as continuing partnership. And this is our team in Tanzania. So when we started in 2021, because we already have clinics for sickle cell disease running, and this was only based in Dar es Salaam, I have to say, not in Tanzania generally. So our goal was to screen through the sickle cell disease clinics to find patients that might be eligible to be enrolled in advanced care for sickle cell disease. And then once we identify the patients, we categorize them whether are they on hydroxyurea or not. So for those who are not on hydroxyurea, we refer them to clinic program that offers hydroxyurea. And if those that are not on hydroxyurea, clinicians are making assessment to see whether they need to optimize hydroxyurea doses. But all of this is happening at what we call advanced therapy clinic. And what we do with the patients that have been referred to the advanced therapy clinic is also to make sure that we do engage with them in terms of providing health education, as well as what we call an an intervention to try to make sure that they have an understanding of what other therapies are there outside of what they are much more familiar, both in terms of bone marrow transplant and gene therapy. So some of the patients will be referred to red cell exchange transfusion program. We do HLA typing for all of those patients to see if there is any likelihood of getting matched sibling donor so that we can refer to bone marrow transplant center. But also we had an ambition of enrolling some of the patients that don't have matched sibling donor, but still do require curative therapies to be enrolled in gene therapy trials anywhere globally. And this is one of our clinicians during the advanced therapy clinic. So far we've been able to screen around 1,500 patients, out of which at least 10% of those patients have an indication to have complications that might require more advanced interventions, such as be put on chronic exchange transfusion program, or will benefit from bone marrow transplant, or if not having a matched sibling donor, maybe a referral to gene therapy programs. So these are some of the clinical criteria that our clinicians are using to refer patients into the advanced therapy clinic, so including previous history of strokes, recurrent vaso-occlusive crises, recurrent acute chest syndrome, patient with vascular necrosis, and so forth. Sorry.
Are these all over age 18, or are they including children?
They are also including children. Yeah.
If they don't have one of these, they're not considered for hydroxyurea.
No, they all need to be on hydroxyurea. No, this is either the red cell exchange transfusion program. Yeah.
On your last slide, you started with 1,000, went down to 300. What about the other 7?
So when we started in 2021, we thought our target is to screen 1,000. So it was a minimum number that we set for ourselves in terms of capacity. But by March 2024, we have been able to screen 1,500. Yeah. So this is above what we estimated in 2021.
So
yeah.
When you're screening, you're looking to see whether they have to move the assets.
No, all of the screening is happening to patients with sickle cell disease. So what our checklist is those clinical indications. So all of these are patients with sickle cell disease. Our screening group are still patients with sickle cell disease already diagnosed and either on hydroxyurea or not. So they might have these clinical complications, but they have not been initiated hydroxyurea. Some of them. Yeah.
But then is the purpose to identify who would qualify for the more advanced?
Yes, based on the complications that they have. So these are some of the clinical presentation of some of the patients, the 164 that we have currently included in the clinic. In terms of the male and female, it's almost 50-50. So we have some patients with stroke, retinopathy, osteonecrosis, and so forth. So the total is 164. We have been able to refer some of these patients to red cell exchange transfusion program, but also doing red cell extended phenotype to all of the patients that are part of the advanced therapy registry. And of course, because blood supply is critical to support the exchange transfusion program, we have been also working with the patient advocates to do blood drive so that we can also making sure that there is continuous supply of blood through our national blood bank. And we have collected at least 107 HLA samples, and 107 from 26 families, and we have typed 15 families, out of which 5 families had matched sibling donors, so which shows at least there is a 33% chance of getting a matched sibling donor. And for these 5 families, we have been able to refer them to our bone marrow transplant center at Benjamin Kappa Hospital in Dodoma. So it was such not a coincidence. We were extremely fortunate that while all these efforts are going on, our government also has put a lot of resources in setting up a bone marrow transplant center, and those were the first bone marrow transplant center for sickle cell disease to be done in Tanzania. And the picture above is our Prime Minister opening up the bone marrow transplant center. So again, as I've previously said, one of the core component that we quite emphasize in our program is the patient engagement approach. So through the patient workshop that we have been able to do, we've been able to engage at least 164 patients, and not only patients, it's patients and families. So for children, of course, the mothers, the fathers, the caregivers will be participating in our workshop just to try to sensitize our communities around more advanced therapy interventions for sickle cell disease. So these are some of the workshops that we had for over the years. And of course, we have also been doing webinars, and also we have allowed our patients to come and visit some of the centers that are participating in the exchange transfusion program to see how it looks like, the lab part of it. And of course, some of those pictures are in one of the visit to the Sickle Cell Disease Center. And most of the work that we are also doing as part of clinical program are also informing our research plan. So for example, the screening component is also, we do systematically analyze the data that we are receiving from the screening itself to identify how many patients from our sickle cell disease patients that are within our cohorts have an indication to benefit from advanced therapy intervention. We also look at the whether there is an efficacy to evaluate the efficacy and feasibility of doing manual exchange transfusion program for sickle cell patients, especially for in our context, if it's much more cost effective to do manual exchange transfusion, and also to determine the availability of HLA matched sibling donors. And also we have our researchers that are working on developing pipeline for CD34 isolation and quantification. But in addition to that, I'm also going to highlight some of the key research collaborations that we have. So one of which we have is the Novartis Institute for Biomedical Research, and the program itself aims to advance in vivo gene therapy for sickle cell disease in Africa. So we were quite fortunate to be part of this program. It has several aims. The first aim is to develop the TPP for both ex vivo and vivo gene therapy, potentially for wide-scale use for patients in Africa. And the TPP itself is meant to provide an outline of the key characteristics of the target product, which is in this case a gene therapy product, either ex vivo or in vivo for sickle cell disease. And I think during that exercise we were able to determine some of the key characteristics, such as what are the target population, what are the efficacy and effectiveness of that. It was a consensus-driven exercise, and fortunately, majority of those that participated in this exercise were also clinicians and researchers from Africa, as well as patient advocates. So a paper based on this work will be out soon, hopefully before end of this year. And also some of the work that I also was fortunate to lead was what we call scope of work B, which is to identify patient-driven barriers, enablers that could facilitate uptake of gene therapy programs for sickle cell disease. So through this project, we do mostly qualitative work. We've been able to engage with around 81 families, so both including caregivers as well as patients. And analysis for this work is currently ongoing, and there are several papers that we hope to get out of this work that might be able to inform the right community engagement strategies. How best can we engage communities when we have to discuss with them when it comes to new therapies, whether gene therapy or any other new interventions that we are bringing to the communities, but also what are the cultural norms that might have an impact into these, if there are any, what sort of supportive care that patients and families might be able to require before engaging into these therapies and so forth. And the other part of this program is to also look at some of the preclinical studies that might be able to be done now. So we haven't specifically started working on that. However, through the scope of work C, we have been able to first establish the clinic itself, be able to develop protocols for identification of the patient, but also the selection itself and recruitment, and also protocols for exchange transfusion, which are all of these going to be potential platforms that are that the scope of work C work is going to benefit. And another program that I wanted to highlight here is the collaboration that we currently have with University of York, which is also through the Gates funding. So for this particular project, the aim is to investigate whether there is an increased risk of having mutational burden, either with sickle cell disease before or after gene therapy. So this is a multi-center study that involves 4 countries. So there is a center here in the US, in Boston, and then there is a center at Imperial College London, and there is a center within our hospital at Muhimbili, and then there is another center in Uganda. So for our center, we do contribute to the data that shows whether there is a risk before gene therapy. So we have been able to contribute to data of patients who are on, or sickle cell patients who are on hydroxyurea, those who are not on hydroxyurea, those who have severe type of the disease, those who have a non-severe type of disease, to show whether there is different levels of mutational burdens among all these different categories, and make comparisons to patients at Dave Williams' lab, which have already gone through gene therapy programs.
So I'm not familiar with this. What is meant by the mutational burden? What are we looking at? Mutations in what cells? I'm not sure.
I will try to explain as a non-clinical lab person. So I think there is already some papers that have been published that shows that there is a risk there is an increased risk of getting some type of cancers after gene therapy. So I think what this work is trying to do is to see whether that risk was already there before gene therapy, or was it caused by the therapy itself after doing the gene therapy itself. So there will be data compared from sickle cell disease patient population in places where patients have not undergone gene therapy, with data that from centers that have already have patients that have gone through gene therapy, and also data from different places, like sickle cell disease patients in London, in Tanzania, in Uganda, whether there is the same level of risk or whether it's different. This is from a non-clinical person understanding of what this work is about to do. But I think the point that I wanted to highlight here, all of this work are meant to set up a ground in terms of our participation into gene therapy trials for sickle cell disease in Tanzania. And another project that we have not started yet, which I think, I'm highly interested in, is to develop regulatory capacity to make sure that we have governance framework for gene therapy clinical trials in East Africa. So this will be a collaborating program between countries in Uganda, Tanzania, and also we have a center in Italy. So it's funded through the EDCTP3, and we hope that through participating in this program, it's a 3-year program. At the end of this project, the goal is to make sure that we have been able to do a situational analysis in terms of what do we have as in East Africa in terms of regulatory capacity, and where there is a need to also develop new framework that will be able to develop governance framework for gene therapy trials for sickle cell disease before we start participating in the trial. So we have not started anything yet, but hopefully by end of this month, we might be able to start the project. And in terms of training, because we understand that having the right human resources capacity is quite key to be able to implement all these high-end therapies. So in terms of training within our university itself, there are several super specialty programs. So I've mentioned here only some of those programs that I think are quite important, and each of them has a role in the cell and gene therapy, in setting up cell and gene therapy programs. And of course, because these are new therapies, and we do acknowledge that we don't have enough capacity to be able to do it within ourselves. So making sure that we are making intentional engagement and partnering with people that are already in the space and advocating for it and doing high-level advocacy is quite essential for us. We've been participating in several conferences, presenting either in panel discussion to make sure that our presence is there and our voices are heard, and we engage in discussions that are aiming to facilitate access of gene therapy trials for sickle cell disease in Africa. So these are some of the high-level advocacy that we were able to do for over the years of the program itself. And I think the highlight itself is our participation in the 3rd International Summit on Human Genome Editing in March last year. And we have 3 participants from Tanzania, and each one of us had an opportunity to present some of the work that they've been shared. We had a patient advocate also participating. Professor Julie Makani was part of the organizing committee of the Human Genome Editing. So I think all of these efforts put us in a position where we are quite engaged in the discussions around gene therapy. And of course, we have several partners at national level, regional level, and global partnerships to be able to work with us throughout this journey. So for example, BKMS is supporting us with the HLA typing project. We had the European Society for Blood and Marrow Transplant team visiting our center to be able to do assessment whether we have the right infrastructure. And we had Novartis team also visiting our center. Caring Cross also visited our center at some point. And of course, we are lucky to have quite huge commitment from our Ministry of Health, the Muhimbili National Hospital, as well as the government of Tanzania in most of this work we are doing. And we are part of the large Sickle in Africa consortia that we can leverage into. And specifically, I also wanted to highlight some of the work that are being currently done by Caring Cross, which we think are quite essential in facilitating point-of-care manufacturing for CAR T cells and potentially gene therapy to countries in LMIC. So this I've borrowed from Rima Sorrenta's slide, which shows that based on the model that they are currently using, they've been able to gain partnership with Brazil and India in facilitating CAR T cell manufacturing locally. So I think these are some of the issues that we are looking at when it comes to facilitate access and participation in gene therapy trials. And of course, our government has continued to commit. This unfortunately is written in Swahili. Perhaps Sarah might be able to read. Yeah, so the government has also committed to support 20 children with sickle cell disease, fully funding for their bone marrow transplant. And I think this is quite a huge commitment for us, because we believe these centers will potentially have as an opportunity to build gene therapy platforms. And I'm bringing back, as I'm nearing the end of my presentation, I want to bring back the slide that I've previously used in terms of how the different roles that academic and research institutions in LMIC has, the government support, how is it essential in terms of facilitating development of gene therapy at local level, but also the engagement of participants, which is extremely necessary throughout the stages, and of course, leveraging with some of the partnership with commercial. So for example, the engagement that we currently have with the Novartis Institute for Biomedical Research. And in conclusion, and I'm bringing back the question of whether are we raising our hopes too high to start dreaming of, oh, it is possible for majority of patients with sickle cell disease in Africa to be able to access these. And I hope that based on the local efforts that have highlighted in Tanzania, and perhaps similar efforts are also happening at the same time in other African countries that have highest burden of disease, whether this in itself is enough to give us a lot of hope, which I believe we do. And because I'm a bioethicist, I think we have an ethical responsibility to ensure that there is majority where the burden is where the resources are set. So I think the burden itself has to be able to be a driver of where the discussions around access should be happening. But again, this is a disease with quite huge morbidity and mortality. So I think it makes this an ethical responsibility for us to do more than what we are currently doing. But also some of my work that I've done with PhD, I've worked mostly with women. So there is huge disproportionate burden of care to mothers of children with sickle cell disease. So by bringing curative therapies to these families, we'll be able to save a lot of time that these mothers are spending on these children, and therefore they'll be able to participate in other economic activities, other education activities, which I think in some ways will be also responding to the sustainable development goals that we have put ourselves into. And I believe the efforts that are being happening currently locally in Tanzania has shown our readiness and preparedness as with all the resources that we have, the government commitment that has been continuing for over the years, but also the partnership that we have been built both at the national level and global level in terms of providing us with support. Of course, there are gaps that needs to be filled before we start even thinking anything big. So for example, do we have the right regulatory capacity to be able to protect the trial participants and so forth? So this is extremely important to have in place. And also I've added this gap when I went into the SGCT meeting, and of course, based on the presentations that I've been hearing from, of course, very well-resourced centers, and in terms of the eligibility, how the selection itself of the eligibility of those centers, and whether if those are the criteria that will be used for centers in LMIC, whether we'll be able to qualify, or whether there has to be a different standard in centers that are in much more low resource context. So of course, there are eligibility issues to be able to be a clinical center, to be part of this high-end technology. So those are some of the issues that I also wanted to highlight before I end my presentation. And again, as I've previously said, I think this is quite the right audience for me to talk about these issues, because I believe the Penn Center for Global Genomics and Health Equity is exactly interested in issues like this, to be able to do work that also will advance equity and affordability of all these gene therapy programs through partnerships and so forth. So I felt like this was the right audience for me to select this topic and share it with you, and hope that I'll be able to get inputs from you. And yeah, thank you very much.
Time for questions? I guess again,
Thank you, Gavin. That's okay.
Send that around.
Getting it, you have to send it around. Yeah.
It gives a global perspective.
I think it's an excellent. Yes.
It's a great.
Thank you.
Having said that, on your presentation, a couple of points. Number one, when you deal with industry like Novartis, I was something that comes to mind, of course, is a long-term benefit sharing. And regulation. I'm glad that this became up now in the industry.
Yes.
Your campus
on regulatory.
Which is great. I wish that regulatory capability
would have started
even earlier.
Okay.
So in terms of the agreement that you have with industry, the long-term benefit sharing and issues around that, because yesterday I was attending another virtual conference, Rare Disease in Africa, engagement. Something that was discussed heavily was this one, like
benefit sharing,
what should be done, you know, do you mind reflecting on that?
Yeah, thank you. I think that's a huge question, like in terms of how are we weighing in on the issues around benefit sharing, especially when the program themselves are at a very early stage. So for example, we are not doing any gene therapy program currently in Tanzania. So I think it's a little bit tricky to bring the discussion of, oh, so now if we have the product, what is going to happen? Because the program itself, I think, of course, the regulatory component wasn't there within the NIBA collaboration. But what I like and I've enjoyed highly is the TPP work that we have done, which I think is going to benefit not only Africa, but other LMIC countries that are also hoping to go through the journey. So it provides
What is that? It's a TPP?
Target product profile. Yeah, so I hope that once we publish that paper, it will be extremely useful in outlining what are characteristic features of the ex vivo or in vivo gene therapy product for sickle cell disease that can be widely used in Africa, both because it has highlighted both the minimal and optimal criteria. It feels like a roadmap to me. So I think these are things that I think that will stay not only for the project period, but these are useful documents for a very long time. So I think to me, that's quite a very sustainable deliverable out of that program. But of course, I'm extremely proud of the work that we have been doing with the patient and families, because all of those workshops that we have been doing, all those, because when we started, we also didn't know, how do we even start having this conversation in this setting? How do you start telling a mother, oh, what is your understanding about gene therapy? Like, what is gene therapy? Like, so I think when we started, we also didn't know how do we even, like, how, like, these are quite costly therapies. Like, people are worried about hydroxyurea. Like, people are worried, about quite immediate needs. Why are you telling me about something that will cost 3 million, that of course I know I won't be able to access it, or my child will not be able to benefit from it? So I think it was quite tricky for us to start having this conversation. And I think we built from us not knowing, and we started building that knowledge production from quite low level to up. And I think the engagement framework itself that we have used, the deliberative engagement, to how we have also introduced the qualitative and the method paper itself, I think it will be quite useful, not only to us, but also, so those are the quite big deliverables that I think are still important now as we set our stage into going into the clinical trials phase, because the program wasn't a clinical trial program that we are having in Tanzania. Yes.
To hear your opinion on that discussion point number one about are you reaching too high? When patients and their families are given the informed consent for gene therapy here, and they read all the potential complications.
Yeah.
Many of them say no.
Okay.
But yet I was struck by the, I mean, there are drugs like hydroxyurea that decreases crisis time, children and adults.
Yeah.
There are a bunch of new small molecules in the pipeline that are showing a lot of promise.
Okay.
So I guess I wonder whether gene therapy is the direction to put your emphasis on over the next 5 years.
Yeah, absolutely. And I think it's fair to ask that question. And of course, I do agree that not all families will even be eligible. So for example, even the current programs, they're recruiting children above 12 years of age. And the burden that we have, for example, in Tanzania, in terms of the high mortality, is children below 5 years of age. So I think even the eligibility criteria itself leave other patients there are patients that might not have access to those therapies because they're not eligible, even if they want to. So of course, in parallel to having these discussions, while we know that not every patient will be able to access these, there are continued efforts to build comprehensive care programs for sickle cell disease. For example, to make sure that not majority, but every patient with sickle cell disease has access to disease-modifying drug, whether hydroxyurea or the other new therapies that you're talking about, voxelotor and so forth. So I think there has to be efforts that are also working to ensure that there is enough access of those disease-modifying drugs, but also making sure that they are affordable. It's not only the question of access, but what sort of insurance schemes will be helpful for families, for them to be able to access this, so that the burden is not being pushed back to the families themselves. So I think there is a lot of that. There is newborn screening coverage that we have also to identify these children quite early on and enroll them into comprehensive care programs. And I believe by doing that, by identifying them early, enrolling them in comprehensive care services, making sure that they have fully vaccinated, perhaps the under 5 mortalities that is contributed by sickle cell disease will also go down way much. So I think I agree with you. I agree with you that there has to be attention on all those other things. But I think the argument that I'm trying here is also to say that we also need to make sure that for those that need curative therapies, access is also available for them. Yes.
Yeah, just following up on that, I asked the same question at Amboise One Council. Isn't you work with the Johns Hopkins?
Yes, I know he's at Johns Hopkins.
And I said the same thing, and he feels strong. He's like, no, like we want to go for gene therapy, and we're gonna figure out a way to do it until it gets done. And maybe he's being overly ambitious, but he also says now the charge is for somebody to come up with a more affordable approach. And that should be the.
I think the charge is to come up with a less toxic approach. And some, I mean, right now you get a bone marrow transplant and you have to get exposed to cytotoxic drugs. And yes, maybe if there is genomic instability, that's not a great recipe. And all of the secondary, or all the malignancies that I can see, they've all gotten busulfan or some drugs anyway. And so I think that they will come, but I think for the next 10 or 15 years, not that anyone cares about them. I think implementation of existing therapies easier to tolerate therapies, better short and intermediate. Yes, someday when someone comes up with a smart nanoparticle delivered therapy. But if you have everyone integrated into your system, you'll be able to roll that.
That's what you're doing, right? It's getting into that when she gets to that day.
We have set ourselves in terms of what are the protocols for patient selection. Do we have the right training in place? Do we have the centers and so forth? But it's not to say that this is all where the efforts is. So I totally, so I think, for example, for perhaps children with sickle cell disease and stroke, like, and also high risk of getting a new stroke later on. So I think for them, the options might be, as you said, because you either stay with the disease, which is also like quite risky, or you also, it seems both alternatives aren't good enough. Like it's either it's to ask them that, oh, you know what, these treatments are risk, but I already have a disease itself, which is extremely morbid to me, and so to tell them to wait until when a much more like affordable, a much more simpler and more, I'm finding it a little bit a hard discussion to tell. Yeah.
Even in a relatively resource-rich area, most people are trying to get them.
Although I'm also wondering even about the understanding of genetics. How is that a barrier? Are people concerned about these gene therapy? You know, are they concerned about gene therapy generally? Stigmatization issues, right? I know that's been a concern. I think genetics research in Africa, that could be a concern of even being labeled. My family has this genetic disorder. I mean, I'm just wondering about some of those issues.
Okay. So most part of my PhD work has been looking at things like that, like for example, having a child with sickle cell disease itself, but I've mostly looked at it from like a gender perspective, again, because I didn't start intentionally to say, oh, I want mothers to be involved, but of course those are the caregivers, those are the people that you interact with in the clinics, but also those are the people that are enrolling their children into research, so you end up working with mothers. So I think there is a lot of I could say clearly the disproportionate burden of care, and some of which are driven by issues that you're currently raising, like maybe stigma or blame that, oh, you have the disease has been coming from the mother. So I think part of what we are continuing to do is to work at community level to provide health educations and to try to explain the inheritance pattern of sickle cell disease, but also I think focusing mostly on regions where the burden of the disease is also high. And so I think we are doing it in every part of it, like providing health education and most of the other things that I think are aiming at improving care. So for example, the paper that I've published on the influence of gender into the quality of care, and I had to bring in the quality of care part because public health people wouldn't be interested in just saying, oh, it's the mothers have the most burden of care, because it's the same in every disease. If you have a child with HIV, then it's your problem, the mother. If you have a child with a disability, it is the mother's burden of care. So I think what I also bring in those conversations is in families where men have been supportive or accepting of the situation and be there for the children, it seems there is an improvement in the quality of care. So for example, small things like the father being able to buy the insurance and say, he might not come to the hospital, but the father might be able to make sure that the child has an insurance to make sure that they attend all the clinics. They are able to get access to hydroxyurea and so forth. That has facilitated a lot in terms of improving the care. But also, the clinics, not only in Tanzania, but also even here, I visited I was having a discussion with a neurologist at Johns Hopkins who's also working with sickle cell disease children. And I was talking about the long waiting time. And she said it's similar even here. The waiting time is also quite long. So for mothers to spend a lot of time in the hospital, they need to eat, you need fare to come to the hospital. So for a father to be involved in terms of making sure those issues, he is able to provide those so that the mother can focus on the care is in itself a lot in terms of contributing to the improvement of the child care and potentially quality of life of the child. So
and this is compounded considerably by when someone is in a very rural area. They may not even have a ride to get to a clinic, might be hours away,
absolutely,
a day away. Have a ride to get there. Have the money.
That's a lot.
We have questions online, so let's give those online a chance. So, there is one from Coleridge.
If I say your name.
It says, helping people understand that gene therapy can be complex. And I'm wondering what you think about informed consent and how to help people understand this, especially given the vulnerability of people in Tanzania. I didn't see that nurses are also being trained in gene therapy, as they are usually responsible for recruitment and retention of participants in clinical trials. It's not like a loaded question.
Okay. So I will talk a little bit about the informed consent part. So my first interactions with families and patients with sickle cell disease was immediately after I did my master's here in bioethics. And for my MPhD dissertation, I was trying to understand whether participants who are enrolled in these complex genomic studies, really understand the study details that they have been involved, and what are the ways that we can facilitate comprehension. And the study itself that they were enrolled was on determining we were talking about it before this talk, the clinical heterogeneity of sickle cell disease and why different patients have. So I was quite curious to see the families, like, why are you participating? Do you know why you're here? What about the study details? And it was and I was linking all of that to low literacy level. My assumption was, you know what, because we work in communities with low literacy level, perhaps that might have contributing to people not understand. And part of the results were opposite of that. That's what I found. So what I found was how the information was communicated to like, how did you communicate the information? Which language did you use? How much was the consent, small or big? Like, how long did it take you? Because we are quite lucky because we work with patients with chronic illness. So they are part of the clinical care. They're coming to the clinic. So they don't mind like asking more questions. So people have questions that they want us to ask. Do you have time to respond to those questions? So the issue was not on the informed consent, but rather on how the consenting itself was done. The literacy level didn't have anything to do with understanding, but how did you package the information to make sure that it is being well understood by a participant from different levels? So for example, I was giving John an example earlier. I did interview a mother who doesn't know how to read and write. And of course, I came in with my like 10 long page of consent, and I was planning to say, okay, do you understand the objective of this study? Or do you know that? And in my head, I'm like, yeah, the study is trying to understand, to determine the clinical heterogeneity. I have all of this in my head. And then it humbled me to know that there are different meanings that families and patients put within the interactions, within their research interaction itself, the consent itself, and what is useful and not useful to them. And it wasn't wrong. It was a learning process for me, but it was, so for example, because the mother, of course, I didn't ask what is clinical heterogeneity, and all of this is done in Swahili. I end up asking the mother, can you tell me your understanding of what research is? And the mother was extremely eloquent in a very simple words in Swahili to explain why she's there, what research is about. She didn't have the exact words as put in the consent, but I think that in itself was enough for me to say, I think she's ready to be enrolled. So she didn't have the right terminologies. She didn't have the understanding. No, and I'm wrong to say the right terminologies because that could be subjective, because this is based on the training that we have as bioethicists. This is what is supposed to happen. But it was enough based on the explanation for me to say she has enough understanding of why she's bringing her child here, what research is about, but not only that, the intended goal that she has. I might have it, like as researchers, you have a different goal on what you want the research to do. But as a mother, I might have something else that I'm like, why am I participating in this? And I don't care about you looking at the clinical heterogeneity. I want the interaction with you. I want, because sometimes when you ask those questions, they'll be like, oh, why is my child not doing well? Why is my child hospitalized? But you're just pushing yourself into, oh, do you understand the consent? Do you understand? So I think we talk a little bit with John in terms of the ethics as the theoretical ethics as what we want it to be, but also the fieldwork ethics, the day-to-day ethics that is happening within these interactions are also quite important. So what I'm trying to say is the informed consent as the textbook informed consent and how we understood might be different from how it could be when it comes to gene therapy, but I don't see how, because even with the interactions that we had currently with the families, they know enough about what they want to know about gene therapy and what's in it for them, which is for me enough to push like, oh, do you know in vivo? Do you know manufacturing? So I don't think some of the details make sense to them because it's enough for them to know, this is what I want. This is what I want to know. What are the risks of these therapies? How long is it going to take? Like, so for example, something that we didn't think about, a mother was asking us, so when I am in the hospital, in this maybe transplant center for 4 months, who's going to take care of my children, my other children? And the father also asking us, so when I'm also supporting that, who's going to bring food at home? Like, but, and then even the patient themselves, which are adult patient, even the decision to participate in this gene therapy trial also depends on whether they will have enough support networks. Like for me to commit to a 6-month program, I will have to ask if my support care system is ready for me to enroll in something like that. Because what if I need something and nobody is there? So I think there is a lot in it than I think.
Well, thank you.
Yeah.
Thank you so much. We are
Oh,
over
sorry.
time. So maybe what we'll do is if we keep track of some of those questions and who asked them, maybe we can actually either be in touch with them by email or something. I can put you in touch. Thank you so much.
Thank you for
informative. I really
inviting me.
appreciate it.
Thank you for inviting me.